Okay, so we're going to get started with our patient panel, and I'm going to kick off the proceedings with one of my clinic patients, Paul Clune. And then after that, Dr. Goldhaber will come up here, and he'll share his experiences with one of his patients. So I follow Paul in my vascular medicine clinic, and Paul has his own story to tell us about his dealings with venous thromboembolism. And Paul, why don't you just start by telling us your own experience with VTE?
Well, starting off, when I was younger, I was a what you call a everyday athlete. I played sports. I went on to play competitive hockey, and then went on into a career of orthopedics. I was playing sports, playing hockey, basketball, 3 to 4 nights a week, and I was inflicted with a diagnosis of bilateral pulmonary embolism. I had no signs of any symptoms except that I had some pain in my left calf I was running a marathon up in Chicago. I flew back home. 6 weeks later, I had some calf pain again and developed to what I was diagnosed with by my primary care physician as bilateral PEs. My scenario was that I work in an emergency room. I'm an orthopedic technician, and the scenario came about that most people present themselves to the emergency room, get treated by a physician there, and then sent on to the x-ray department. I was that healthy person sitting in front of them with no real signs of any symptoms that were life-threatening. But once I received the CAT scan in the x-ray department, all the bells and whistles started to go off. They started to call emergency help. They had to get me on oxygen. They had to get me on other things because I just started to deteriorate in front of them, but I was not feeling any of the real symptoms except that the things that started to show were my nervousness because I really didn't know what was going on yet. I was treated with IV heparin. The first dose was in the first 15-20 minutes of finding out that I had this diagnostic bilateral PEs. Being nervous, being upset, not knowing what to do because there was nobody around because I was just going in for a simple exam and no family members or anybody. So it was unnerving to find out that this was all was happening, and there was other decisions that were also had to be made, whether I should stay in the emergency room or should I go up to a floor. My wife is also the nurse manager of the orthopedic floor, and she was asking me what I wanted to do, and I said, first of all, I don't know what's going on. I need some people to come around and talk to me. So being part of the North Shore Medical Center family, a lot of physicians got involved in my care. Again, to reiterate that once the IV heparin went on board, the oxygen was on, and a team was put together to take care of me. Now, it can happen to anybody. It can happen to anybody wherever, that if you come up with this diagnosis, I wasn't aware of what was happening. What also occurred was hereditary. And Dr. Piazza and I talked about this in detail, is that both my parents died of pulmonary embolism, one of a stroke, my dad of a pulmonary embolism. So I had those risk factors that they talked about today. So now that we're at this stage where I am today, I am grateful that Dr. Piazza and Dr. Goldhaber were allowing me to come up here and speak to you. I've been on Coumadin for the duration, and as we plan on the future with the new drugs coming out, I'm going to stay on Coumadin, and that's my choice, my discussion with the doctors, and what the studies are going on as we sat here today, listened to the research that's being done on all the new medications that are out there, where I felt that my condition was hereditary risk factors instead of just the other simpler factors that are involved with your proteins and your Line 5s and everything, but that was my decision to do.
And one of the interesting things in taking care of you, Paul, is that anticoagulation, blood thinning, has an important impact on your lifestyle because you're an athlete. You're used to being physically active, and now all of a sudden you're on this medication that has a risk of bleeding, and some of the activities that you're used to doing and that make you happy aren't really safe options anymore. Can you talk a little bit about how anticoagulation has impacted your physical activities and how you work around that and how you stay physically fit despite being on a blood thinner?
Well, to take a few steps back too, when I was in the hospital and they were asking about filters being put in because of the age factor that I was in, my activity level, and not having to have clots occur again or any of that. So when the time came for that discussion to have the filters put in, I denied that only on the education that I got from my friends at the North Shore Medical Center, interventional radiology, and the doctors that actually do all those procedures. We sat down and talked it over. So I decided to go that route. The anticoagulation has been a problem for managing as far as my activity levels of my contact sports. I can't play hockey anymore. I can't play basketball anymore. I can't ski Sunday River anymore and go down White Heat because of not only my situation that I go too fast, but the people that I could run into or the running into me, and that the bleeding factors. So understanding that Coumadin is one of the foremost medications that have been out there, and it has a study of almost 50 years of being out there. How does it work for me? Well, managing the INR, I'm also was fortunate enough to have the doctor prescribe a home INR tester for me so I can actually test at home and not have to make a schedule to formally do every week or every 2 weeks, but actually able to do it at my time and when I could do it. It works for me. The Coumadin actually works. I'm healthy. I've actually I work out 5 days a week. I'm on a treadmill. I do some play basketball, but it's all by myself at 5 a.m. in the morning because I work at 7. So I go and shoot around by myself. I do wish that I could have the freedom of those new drugs, but I'm actually afraid of what happened years ago with my parents, that they didn't have these drugs available. My father was on Coumadin for 6 weeks, and then they was taken off it because of being on a total hip. They did the protocol of 6 weeks on, and then they took him off. But he had that recurring blood clots that they spoke about today, and he didn't survive that. So those are my fears, that the Coumadin is actually working for me. I don't have any bleeding problems. I'm not bruising. I'm not having any of the side effects that they do have. But they do have fear. They do instill fear in me that I can't go and play sports again, which is what I like to do. But I don't think that's going to be something in the future. But if this medication, and if we go forth from here using me, using others, there are other people, other pro athletes out there that are having problems. We know of a few that have atrial fibrillation who didn't survive because didn't follow his protocol. I'm hoping that I can follow this protocol with this group and move on and to find out some cures for other athletes who are afflicted with pulmonary embolism.
Thanks, Paul. That's terrific. One of the other things that we did in our visits, because your blood clot was interesting in that you didn't have a provoking factor that we could really pinpoint. You had some air travel, but it wasn't really long-haul air travel. It wasn't something that we would typically attribute a blood clot to. Yours, you didn't really have a provoking factor. And so we had a conversation about how your risk of having a recurrent blood clot would be high going forward because we couldn't pinpoint the exact thing that you would need to avoid in order to not have another blood clot. And so we had a conversation about the optimal duration of your blood thinning and what medication we should use. And one of the things I told you was that it was something that we were going to decide together. I wasn't going to decide it for you. We were going to make sure that your preferences were incorporated into our decision. Can you talk a little bit about your own thought process as you decided on whether you wanted to be on a blood thinner long term, and your decision to keep going on warfarin and not to try any of the new agents?
Well, I have to say that I attribute it to coming to this conference and sitting and listening to very prestigious doctors talk about different conditions of pulmonary embolism and stroke, because both of those factors play into where my decision making was to pick Coumadin. Researching all of it, I was on the internet and looking at all the different medications that are out there and salespeople that you could talk to and that want to sell the different medications to the physicians. When Dr. Piazza and I sat down and went into detail about it, I was saying to him that I need to have a normal life where I could do certain things to survive, because everybody has their little idiosyncrasies in what they want to do in life. Well, basically, I just want to be able to go out and run with my grandson and play baseball and do all those other things without having to worry about a bleeding factor, falling down, or walking the dog and slipping on the ice and hitting my head and having a head bleed and being left out in the snowbank. So those things were all factored into where I wanted to be, and I researched it enough, and he and I talked about the different levels of what Coumadin does and where it can be and how I need to sort of be in control of that. And he'd guide me to what levels we're going to do with Coumadin. And he and I talked about the other Xareltors and the other things that are, you don't have to keep track of it, you don't have to do the ionage, you don't have to do a pinprick or anything like that. And those are the things I looked at as like, I can deal with the pinprick. What I can't deal with is the long, drawn-out studies that Coumadin has, and that they have done enough studies that the way I work, I do total hips, total knees, and total joints with a lot of orthopedic surgeons, and I follow the patients afterwards, and I see what their results are. And they're on these new drugs as well as Coumadin. Some are on because they were already on Coumadin, and some are on the new ones just because that's the new protocol. I think it's a time thing. It's going to be time before we know what these drugs are going to be able to do for us. I'm willing to try them, but it's going to be on my terms, and I'm in big discussion with the doctors, Piazza, and the rest of them that I got to meet today, because they're showing a lot of data that's coming out that they really didn't know a lot about me, because I was an athlete that was normally healthy, but I have ended up in the emergency room and was thankful for the care that I got when I did, and was able to survive bilateral PEs.
Paul, do you think that the ability to test your own IRNR at home gives you some sense of control over your therapy, and is something that actually helps you to cope with pulmonary embolism?
Definitely. It just gives you that peace of mind that it sees it right in front of you. And anybody that can handle a little computer or your new iPhones, this little machine's just great. You slip a little lab paper in there, and then you prick your finger, you put the blood on, and it does it all. And it actually stores everything for you in case you forget. It's got a memory on it. But I definitely recommend it to anybody that has use Coumadin. It's just a much more control. It's much more peace of mind, because I know what my levels are. And I know the doctors talked about how the Coumadin is all over the place. It's everywhere. I'm fortunate that mine has been in control. It varies from 2.1 to 1.7 to 3.5. I get up to 3.5, they're all over me. The phone calls are coming. The doctors all know about that. I'm at 3.5. They want to know what I'm doing. And all I did is I said, oh, I must have taken an extra pill. I don't know. I have the... It varies, but I don't know. It could have been that I had an extra glass of wine or an extra... I really don't. They say that food alters the Coumadin. Well, I don't deviate. I'm an Irishman. I eat the same thing every day. I don't deviate from it. So there's not a whole lot. There's no whole lot of salt. The diet is strictly what... When I was at the last convention, there was a dietitian, and he gave me an example of hockey pucks, right up my alley. I said, okay, I can do that. Hockey pucks on my plate, and that's how I eat. I just eat small portions, and desserts are there. I can eat anything I want, and the Coumadin levels are controlled, all by that little machine. And I do it twice a week instead of once a week, which was tough to do once a week because you had to find the time of the day just to do it because of my schedule.
And Paul, that's one of the things that I hear from my patients about hesitancy taking the new oral anticoagulants is since you don't draw any levels, you don't test, they always wonder, am I anticoagulated enough to prevent a recurrent event? And that's actually a reason. It sounds like it might be one of your reasons for staying on warfarin.
Well, if I could get some answers from yourself and the other doctors in the room, I'm baffling them because I came in healthy. I'm still healthy. I just have to be on Coumadin to prevent blood clots. It's a decision that if you want to try these new drugs, I don't think they're really got the time or the years behind them in the studies that Coumadin has. And being in the medical field and working with total joint patients and seeing how they survived on Coumadin as well as these new medications coming. But, you know, it's still out there. There's some answers to be had, and this group of physicians have convinced me that I will join and I will stick with this right to the bitter end because I want the baby boomers that I am, because there's a lot of us out there that are afflicted with this. In just the last 3 months, there's been 4 people coming to our emergency room, similar athletes who have pulmonary embolisms. So I think a lot of us are going undiagnosed. Just as I said that there's a percentage of atrial fibs that aren't being treated with some anticoagulants. There are some of us who are out there who've sustained some type of injury in the past and have compromises, and we didn't know about them. And now we do, and we have treatments. In the future is, I hope, that those medications will work so we don't have to keep pricking the finger.
Great, Paul. I think now we'll invite Dr. Goldhaber up. But Paul, I want to thank you for giving us your story.
Thank you. Thank you. Thank you.
Now I'm going to introduce everybody to Ken Laglenne. Ken, welcome to the NATF Patient Advocacy Forum, and we're just thrilled to have you. I want to also ask your wife Trish to stand up. She's been a big part of the story. You probably know, Ken, that this program had 2 parts, atrial fibrillation and DVT. First half was atrial fibrillation, the second half was DVT. How is it that you end up having both problems in one person?
I'm a lucky guy. Disclosure here, I'm not a medical professional. I don't tell good stories. And I don't have a medical bone in my body, so. When I was 18 in college, I was a Division I wrestler. A lot of stress, physical stress, a lot of emotional stress, family stress. I was at Temple University in Philadelphia, and I ended up with Guillain-Barré syndrome. It's a tough disease. I overcame it. Later that year, I had symptoms for about a year. Later that year, I had my first bout of AFib, and I had no clue what it was. At the time, I didn't know the connection between the two. So I just turned 47. I have 2 young kids. So I've been dealing with this since I was 19. Recently, November 16th, I had a total hip replacement, and it went well, but I ended up with a DVT the day after I was discharged. I guess that's what's brought me here.
Okay. So first atrial fibrillation, then DVT, and we had a lot of adventures that we discussed with you and heparin and Coumadin. Do you remember any of those?
I remember them all. It was quite the fiasco, and luckily I had my wife to keep track of all the numbers. And my experience with Coumadin, I had AFib. I think I had a bout in 2010, March of 2010. And it went for 2 weeks. And so we started Coumadin. So that was my first experience with Coumadin. And then we did Coumadin again after the surgery. It's my numbers tended to fluctuate quite a bit, and it's a lot of blood draws. And I don't really like needles. But so we was diagnosed with a DVT, came back to the hospital, went on heparin.
Yes.
And then it was Thanksgiving, and we were able to get discharged with, I forget the name of the injection. Lovenox, along with the Coumadin.
Yes.
And there were challenges with the communication with the clinic, and the numbers and the blood draws, and finally I was introduced to Xarelto, and I don't know of a symptom that I have. I don't know that I'm on it. It's a wonderful drug so far.
So the regimen is 20 milligrams once daily with the dinner meal.
Right.
And is that so? You've been on both Coumadin and Xarelto.
Coumadin.
Do you want to compare?
So the Coumadin it's the hassle of going to the clinic and getting the numbers right, watching what you eat. Luckily, I'm married to a dietitian. That helps. I don't know if it was the dose, but I was very cold. I understood why my grandparents all moved to Florida and my parents in the Carolinas. Also, I don't know if it was the dose, but I ended up with some bad headaches that were scary. But Xarelto, I don't have any symptoms that I'm aware of.
Mm-hmm. Trish, I don't want to put you on the spot, but you were so much a part of the management story. Would you mind coming up and telling us what this was like from your point of view? Trish works at Brigham and Women's, and this was one situation where I think it was kind of, I'm guessing it was kind of hard for you. You had the professional hat on one hand. You've probably counseled hundreds of patients on how to survive while taking warfarin, but now it's your husband. And we did have a lot of communication problems with INR and dose adjustment. Do you want to say, and I think I probably talked with you as much as with Ken about what was going on and what we might be able to do. Do you want to give us basically your perspective?
Well, my perspective, I guess, is a little bit different. I'm in the healthcare profession, so I'm a little more controlling over, I was very in tune to, we need to check the INR, I need to call, I haven't heard from the clinic, I'm chasing people down, I'm emailing Dr. Goldhaber, I haven't heard anything, and he needs his dose tonight. And so I was a little tense about it. We have small kids, I was worried about him, he just had a hip replacement, I was doing everything, it was, we have to go to get a blood draw, it was a lot going on. So it was hard for me to manage, to deal with other things like the INR and, the diet thing, that was fine, we had no issues with that. But then adjusting pain medication with Coumadin, there was just a lot of other components we had to think about with that. And I guess I was just getting frustrated, and probably Dr. Goldhaber was feeling my frustration and came up, fortunately, with another alternative that worked better for us at the time.
And I don't know how many of you have had a total hip replacement. It is a miracle. I'm very grateful to be able to run around with my 7- and 5-year-olds. But the first couple months, you're not much use to anybody. So.
In those compression stockings, I'm telling you.
We almost had to go for marriage counseling. Very thankful I can put them on myself now.
Well, you are a very sweet couple. Any questions or comments for Ken and for Trish? Okay, well, I want to thank you both for sharing your story with us. I hope those of you who are fairly new to the NATF programs will get a sense of the diversity of our membership, a sense of our educational activities, our outreach, and our advocacy. You have the opportunity to meet Melanie Bloom, who's worked on DVT awareness for the past 10 years, is probably the United States' #1 advocate for awareness and education. That will be on March 28th at the Mandarin Oriental Hotel. We have many committees. We continue our work during the year. Our next major event after that will be the Thrombosis Summit in September. But stay in touch, read our webpage, contribute to our webpage, call us up. I think it's just important to remain engaged in this area. So with this, I want to thank all of you for participating in the conference. Greg is chair of the Education Committee. You've done such a tremendous job in our #1 core activity at NATF, and I wish you a very pleasant evening. Thank you very much.